Hi, Dr. Cady here, and I am coming back to you today to answer a question that I dangled out on some of our social media pages yesterday, and that is, what do Sigmund Freud and menopause have to do with each other? And this is something that I've been thinking about a lot lately, and don't worry, I'm not going to be all psychoanalytical on you in this video. I would like to quote what Freud said back in 1912. This was published in his book, Recommendation to Physicians Practicing Psychoanalysis. And Freud had a very interesting idea. He said that one should listen with evenly hovering attention. The way I typically think about it is hovering awareness. You should listen to the patient with a sense of hovering awareness. And he then gave you some subpoints. Don't make judgments too quickly. Don't jump to conclusions. And don't let personal biases influence what you're hearing from the patient. Now let's talk about what's going on in medicine these days. In medicine these days, taken over by big box medicine and insurance companies, there is a limited amount of time for a physician to spend with patients and actually get to the bottom of what's going on. You're lucky if you have 15 to 20 minutes for a new patient appointment. You're lucky if you have 5 to 10 for an established patient appointment. And also, for my friends out there in internet land who are not docs and are not healthcare practitioners, you need to know that us healthcare practitioners are trained to try to put a bunch of things together really quickly, come up with a diagnosis, and then come up with a treatment. For example, and I promise I'll get to menopause in a second. For example, let's say you're a doc and you walk into an emergency room cubicle and there's a patient sitting right there on the gurney. And the patient is sweating and is in distress and says, "Doc, I got this chest pain and I've got this knife sensation in my shoulder and I feel like something is wrong and I just don't know what to do and I don't know what's going on." Well, if you're the emergency room doc, you don't think, I should give this man something for anxiety. I should investigate if he has an injury in his shoulder. I should consider, whether he's been getting enough sleep. The first thing that comes to mind is the guy's having a heart attack, and at that point the emergency system jumps into action and the person is worked up for a myocardial infarction and treatment. That's very quick differential diagnosis and a very quick move to treatment. All right, let's put that aside, and now let's consider what happens when a woman walks into her doctor's office or her nurse practitioner's office or her physician's assistant's office, and she is, let's say, late 40s. And she says, the reason I'm here is that I'm having trouble sleeping at night. I'm jittery and on edge. I'm anxious. I'm feeling depressed. I'm losing my thoughts. It feels like my brain isn't working. It feels like an alien has taken over my body. And I'm really irritable and cross with people. And oh, by the way, I can't lose weight. I'm gaining weight in spite of everything I'm doing. I can't eat less than the rabbit food I'm eating. And my sex drive is kaput. And my husband is upset with me because we don't have sex anymore because I just flat don't feel like it. And you're the healthcare practitioner, and those are the symptoms presented. The fastest thing you can do is you can say, the woman is having a sleep problem, I'm going to give her a sleeping pill. The woman is having anxiety, I'm going to give her Xanax. The woman is having depression and irritability, I'm going to give her Prozac. And the woman is having low libido, oh, well, too bad, there's nothing that I can do for that that's FDA approved because there is no testosterone that's FDA approved for women. So the woman gets an antidepressant, Xanax, and a sleeping pill because of the limited amount of time that's there. So now let's back up and start reviewing what Freud would say. He would say an evenly hovering attention. So let's deconstruct this for a moment. And by the way, the amount of time that you and I are spending on this video is far more than most healthcare practitioners would do in working up a woman who comes in with those presenting issues. So let's consider. So is the woman menopausal? So you ask, are you menopausal? No, she's had periods. Okay, well, check that box. No, not so fast. It's like saying, when does your car need an oil change? Does your car need an oil change when it's gone 10,000 miles past the oil change, or around 3 to 5,000? Maybe you need an oil change sooner. Do you think that a woman's hormones are going just perfectly day after day, week after week, month after month, until miraculously all the periods stop suddenly, and 12 months later, and then you can say, oh, great, now you're menopausal, now we can treat you? No, they don't do that. They start going down like the dirty oil in your car is getting dirtier and dirtier and dirtier while the menopausal transition is evolving. So what happens during that time, even though a woman is cycling and having periods, they may be getting intermittent, they may be getting unpredictable, but my goodness, if she bleeds one time in 12 months, well, she's not menopausal, so I guess we can't treat that. There are several things that are going on. Number one, her progesterone level is dropping. That's one of the first things that starts going down. And when the progesterone level starts dropping, the woman gets anxious and has trouble sleeping. By the way, this might seem like I'm picking on women, but listen, only women get menopausal, and I haven't even started talking about men and andropause, which I will come to in a different video. So the sleep begins to become a problem. Does that mean she needs estrogen? No, but she probably needs her progesterone level checked. So at that point, when a woman comes into my office and I'm evaluating her, there's some specific labs that I will get. One of them is, well, actually two of them are FSH and LH. These are pituitary hormones that go down to the ovaries and they say, wake up, gals, and make estrogen and prepare a follicle to pop off your ovaries so you can get pregnant. That's the way the body is designed. When those start going up and up and up, it means that the ovaries are getting a little bit lazy, a little bit worn out, a little bit like your car that the oil is getting dirty. And so they're going to go up. And your pituitary is really going to work on stimulating the ovaries to pump out estrogen and testosterone and progesterone until they simply can't anymore. So one easy thing to do for a woman that's either premenopausal or menopausal is the use of progesterone. It's been described as nature's benzo. It actually is broken down in the liver to allopregnanolone, which has benzo-like effects in the body. It's one of the reasons why women, after they deliver babies, can sometimes get really anxious and distraught. It's because their progesterone level goes from the hundreds down to practically nothing. It's an acute change. Anyway, that's progesterone and sleep. They don't need a sleeping pill. They don't need Xanax. Next, what's happening with their estrogen? Because as the menopause transition continues and you ease into total menopause, defined as 12 months without a cycle, your estrogen is going down. What most doctors don't know, I'm not kidding you. If you don't believe me, go in and ask your doctor this. Doc, is estrogen a monoamine oxidase inhibitor? And they'll say, huh? Because they've never heard it. But it is. And it's published. And it's in the peer-reviewed medical literature. You can go to pubmed.gov and look it up. Estrogen, MAOI, enter and read what's there. So as some of you perhaps know, monoamine oxidase inhibitors are the most powerful antidepressant known to man in pill form. And the way they work is they block this enzyme in the brain called monoamine oxidase, which I think of as a little Pac-Man, just gobble, 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 that gobbles up all your happy neurochemicals, including serotonin, dopamine, and norepinephrine. Gobble, gobble. When your ovaries are working correctly, the estrogen inhibits that enzyme so you don't gobble up your happy, pay attention neurochemicals nearly as fast, and everything is in balance. As the ovaries begin to fail and the estrogen levels go down, the monoamine oxidase activity in the brain goes up because it's not inhibited. And then, let's do this in slow motion, you lose serotonin, which is a be happy, don't worry chemical. Most of you know about SSRIs and how they work by inhibiting the reuptake of serotonin, basically getting more of the happy juice out in your brain. Well, that's going to go down if your monoamine oxidase is unrestrained. So you'll lose your serotonin, you lose your norepinephrine, which is another be happy, don't worry chemical. And by the way, it helps with focus and concentration. And you'll lose your dopamine, which helps with focus and concentration, and it's also the pleasure chemical. Now, mind you, you don't lose all of it, but the levels that you have in your brain go down. And that's the reason why women in the menopausal transition and also in menopause will say things like, I'm unhappy. I don't know why. I'm irritable. I don't know why. My brain is not working right. I'm feeling like I'm scattered and fragmented. I can't remember stuff. I could keep up with my house or I could keep up with my career, and now for some reason I can't. And it's because the estrogen is going down, which means, I'm repeating myself so you get this, the estrogen is going down because the ovaries are beginning to retire. And as the estrogen goes down, the monoamine oxidase inhibition goes down, which means you gobble up your happy, pay attention neurochemicals, which means things go south in a hurry. The third thing that happens in the menopausal transition and in menopause is you begin to lose your libido. And that's because testosterone in the woman's body is made in two places. It's made in the ovaries, and it's also made as a downstream metabolite of something called DHEA, which is secreted from your adrenal glands, which are these little walnut-sized and shaped glands that sit right on top of your kidneys in the back. DHEA is an energy hormone. It helps balance glucose. It helps hang on to bone. But it also, not only does it give you energy by itself, but it also gives you energy by being converted into testosterone. So when your ovaries are working, you have a double supply of testosterone. You have it from your ovaries, and you have it downstream from the adrenals. When you hit menopause, or when you're going in and about to hit menopause, in the premenopause, your testosterone levels are going down. When that happens, your energy goes down. It might also impact your brain functioning, so you don't feel as sharp. So that's estrogen and testosterone, which is accounting for your brain not feeling as sharp. And it will certainly do a number on your libido. So no more sex drive, no more desire, nothing like that. You're going down. So there are a couple of ways you can handle this. Number one is if you go to a conventional practitioner, you can get put on a SSRI for your depression, and maybe it would help with your sleep. And that can further increase your likelihood for weight gain and sexual dysfunction. I mean, ladies and gentlemen, some of those SSRIs will just numb you out down there. And it not only numbs out women, but also men. So you won't feel like having sex. Even if you're having sex, you can't have an orgasm. And this is for treatment of what ails you, and it's going to make things worse. So that's the serotonin, that's the depression, that's the knee-jerk prescribing, because, to go back to the very beginning, the physician or the healthcare practitioner is not listening with that evenly hovering attention. Because if they were, instead of trying to smush it all into, you're depressed and anxious, take Prozac and Xanax and see me in 3 months. Instead of doing that, they would say, not sleeping. Let's see, where is this woman in her life cycle? Oh, well, maybe she's about to grade into menopause. Maybe her progesterone is going down. Okay, check. We'll use progesterone. And maybe her estrogen is going down. Now, that's a little bit more dicey. You have to be careful about using estrogen before a woman is totally in menopause, because bad things can happen. And, oh, look, her libido is going down. That's probably the testosterone. Maybe we should use a little testosterone. So the rational thing to do, you don't do it just by symptoms. You listen to the symptoms, evenly distributed attention, and then you think, maybe this is what's going on. We need to do some labs. So the way I typically do it is if a woman is still erratically cycling, I will wait until day 12 of her next cycle. Day 12 is defined as you bleed for 5 days, and then you have the next week, which is the follicular phase, and it's the phase that most women tell me they actually feel the best, is the week after they finish bleeding. Think about your own experience. The end of that week is day 12. So that's when we get the labs, and we get LH and FSH, the pituitary hormones. We get estrogen, progesterone, free and total testosterone, and something called sex hormone binding globulin. And we also get DHEA, sulfate. DHEA is what's secreted from the adrenals, but DHEA sulfate is the storage form in the blood, and it's also the actively treating type of hormone. It's the DHEA that plugs into the receptor, so DHEA sulfate, and we check that. And then also I would check a CBC, a complete blood count, because if I'm thinking about using testosterone, that might inflate your so-called hemoglobin and hematocrit numbers a bit. Hemoglobin is the oxygen-carrying molecule in the red blood cells, and hematocrit is what is the percentage of your blood that's the little red blood cells floating around in solution, and you don't want to jack it up too high or you make the blood too thick. So that's how I would listen to a woman coming in with Freud's hovering sense of awareness, how I would conceptualize it, how I would work it up, and then I think I'm going to tell you in another video exactly how I would treat it, because I think that's enough for today. So thanks for watching. Really appreciate your being here.